Good morning, everyone, and thank you, Josh. Really excited for you all to be here. Again, my name is Rebecca Daly. I'm a doctorally prepared nurse executive. Happy Nurses Week to any other nurses in the room. Really focused on bridging the gap between patient care and outcomes and policy. My fellowship studies have been focused on the relationship of interoperability and maternal health. And interoperability is the exchange and make use of health information data. And so I will focus on that in my second year at the Department of Health and Human Services Maternal Health Task Force to continue my endeavors. Today's panel brings together a dynamic group of leaders to discuss the shift from mandates to movement and interoperability and deliberate the big bang of interoperability as termed by Secretary Baceres. For too long, vital health information has been siloed in different electronic health record systems, creating a fragmented picture of a patient's health journey, leading to medical errors, delays in care, and treatment duplication. But the good news is interoperability holds an immense potential to transform healthcare. Our esteemed panelists will delve deeper into the current state of health interoperability, considering providers who are and who are not under regulatory mandates and how to reach these areas and specialties, infrastructure limitations and financial considerations, and ensuring patient access to all, just to name a few. To lead our panel, I would like to welcome Dr. Oliver Aalami. He's the Director of Digital Health at Stanford Biodesign, to the stage to moderate this morning's panel. Thank you.
Still miking up, but I'm just going to go ahead and get started since I have a little intro. So first of all, how many have heard of the word interoperability? Okay, so you're pretty well informed.
Yeah.
But we're pretty impressed. But despite that, Brendan's still getting mic'd up. But I just want to give a little background. I want to thank Rebecca, for the introduction. We spend in this country 17% of our GDP on healthcare, the highest in the world, and despite that, still have outcomes that are amongst the lowest globally. To help bend these cost and quality curves, the Affordable Care Act was passed 14 years ago now, in 2010. $30 billion in financial incentives were provided to digitize electronic health records with basic implementation requirements. However, the data remained largely siloed. To address this, the 21st Century Cures Act in 2016 set broad rules and frameworks to improve interoperability, and the final rule in 2010 mandated specific requirements to enhance interoperability, including establishing the FHIR API data exchange standard, prohibiting information blocking, and also expanding accessible health data types set by the United States Core Data for Interoperability. And as one of the final acts of the 21st Century Cures Act, the ONC established the Trusted Exchange Framework in Common Agreement, or TEFCA, which you'll hear a lot about, a framework that supports a nationwide health data interoperability network, a network of networks that has been dubbed to be the Big Bang moment for interoperability. So you just heard a lot about policies to mandate interoperability. Yet as Rebecca's work has highlighted, we're far from seeing widespread movement in this space. So we're lucky to have a diverse group of panelists today to discuss some of the wins, some of the challenges. And with us today, we have Deven McGraw, a policy wonk insider, formerly with HHS, now Chief Regulatory Privacy Officer at Ciitizen. We have Rob Klootwyk, who's the Director of Interoperability at Epic. You may have heard of that EHR system, and board member of the Sequoia project, which we'll hear about a little bit as well. Then we have Jennifer Blumenthal, a relentless patient access advocate. So thank you, Jennifer, for all that work. Who's also the founder and head of product at One Record, which is a Milliman Intelliscript company, also board member of the Sequoia project. And then last but not least, we have Brendan Keeler, the notorious health API guy. You have to look up his Substack. He just dropped an article this morning. Who is also head of product at Flexpa, a claims API on-ramp company. So thank you all for joining us today. I know you're very busy to help us highlight the wins and the challenges of in interoperability. And what I'm really excited about this panel because you represent kind of different aspects of the healthcare ecosystem. And you've been in this business, before I would say from the very beginning, when all these mandates came into play. So I want to kind of take a, solution-focused framing approach and ask you each, what worked well and even better if, and maybe we'll start with Deven.
Sure. I mean, I think we have this tendency to think about the ways that interoperability, the movement of data for purposes that are lawful and that are needed, we have a tendency to think it isn't where it should be, without a doubt. But at the same time, interoperability is happening. Exchange of data for treatment is much more robust than it used to be. I know that I recently moved from the West Coast to the East Coast, changed medical providers, went in to see a doctor for the first time. She had all my meds. She had my history from where I had been before, which never used to happen. The patients had to port that data if it moved at all. And that was extraordinary. Frankly, I think it was because both of those healthcare providers were using Epic, which was really a pioneer in making sure that its customers at least had interoperability, and now is taking a lead on in the country at making sure that systems are interoperable. But so it's happening again. Treatment is probably the use case that is the most robust, although again, we still don't have complete interoperability there either. But we're definitely seeing what's possible when systems can share data with one another, both from a technical as well as a policy standpoint.
Perfect. And then
Sure, I'll add a little bit maybe to the background on what Deven just alluded to, which, by the way, I did not know she was going to say that. But
there was no exchange of money. It's true.
My declaration of conflicts. Yeah. So I started at Epic about 20 years ago, and shortly before I started, our founder and CEO, Judy, her husband, a practicing pediatrician, had a patient he was caring for with a rare chronic disease. And the little kiddo was out of town, wound up with some complications in the ER. The ER physician at the time did completely reasonable medical care, but was unaware of that rare chronic condition, and unfortunately, the child passed away. And he was very distraught, Judy's husband was, and they would have known what to do if they would have known. It wouldn't have been that hard. They just didn't know. And so Judy went around and was kind of talking through how do we solve this problem? And it wasn't really a priority at the industry at the time. But we said, okay, fine. How do we make this stuff? Wherever the patient goes, her chart follows her, And so we set on in creating care everywhere. That's what it's called now. And really what it needed was kind of three key ingredients. One, we needed the technology, which as a technology health IT developer, we could kind of create. Two, we needed a shared set of common agreement, if you will, or rules of the road. How is this going to be? How can I trust everyone? Because we wanted it to happen wherever they went, across the country, we now call it the galaxy-wide network. We're a little bit nerdy, but that's okay. But it is international even, and they exchange, and it's built on that foundation of those rules about how you're going to be doing it. It's only going to be providers providing treatment, and here's the set of rules of engagement. And then we needed a exchange directory of all of those providers, their locations and endpoints, and how to actually know who I'm connected with. And that was working pretty well. We got a lot of sites on Epic going live. It was very hard. First couple of years, nobody wanted to do it because there was, this was the early 2000s, mid 2000s, and competition, all those types of things. But now we held to the, half share, no discrimination, doesn't matter. And eventually, the snowball effect has happened. And we had a challenge though, where if you weren't on Epic, we didn't have that same type of effect. We had our network, but then it was point to point, and that was really hard. And then you couldn't join the full directory. So how do we kind of replicate those three things in a more ubiquitous way? And so we founded Care Quality in 2014. We were a founding member of that, where it's basically built on that. Rules, a directory that they host, and then an agreed upon set of standards of that technology. Those matured over that time, and now they're kind of everyone agreed this is how we're going to do it. That's been quite successful. About 70% of the US hospitals, 100% of Epic customers are all on it, and about 70% of the US is connected. And we exchange 15 million records every day among the Epic community, half of which are with other vendor systems, most through Care Quality. But that's kind of plateaued. So the past few years has been about 70%, which is that gap in care, the rural, some of the post-acute, urban, under-resourced orgs haven't yet either gotten the technology, haven't figured out how to, plug into that thing. And it's also plateaued with treatment, because that's what it set out to do, was just treatment, and which is great. It's a very vital part of everything. But it hasn't really been able to evolve beyond that over the last few years, which is why we're really excited for TEFCA, having the government sponsor behind that network of networks. Doesn't matter if you're AT&T, Verizon, you can call, text, all that stuff. So TEFCA can bring that clarity, so then it doesn't matter. I don't have to talk, wait, are you on Verizon or AT&T? It doesn't matter, right? I just get one. And that clarity that the country needs, that says, just, are you part of TEFCA? That's a simple question. If the answer is yes, great, we're connected. And what TEFCA really, I think, also has to offer, beyond getting everyone connected for treatment, is individual access, so the patient access at scale in a safe and effective way using FHIR, the technology that everyone kind of wants on that front, and then getting public health up and running. So again, that's a lot of bespoke stuff for public health today. TEFCA can unify a lot of that, reduce administrative burden with payer exchange, for payment and operations, and even government benefits determination. And TEFCA did a great job, talk about mandates to move what's working. At the beginning, TEFCA said, we're not just about treatment. We're going to do all of these, but we're going to do them in a stepwise fashion. But at least when you go in eyes wide open, knowing it's for all of this. And eventually all of it is going to be required. But we're going to do it together and make sure that it is safe, effective, and protects patient rights. So
that's a big win. Jennifer, what were some wins?
So I represent like the developer innovator experience. So I built an app that allows you to get your data and share your data with people that you want to share, very similar to how to use like Zelle or Venmo. But for me, the hardest thing was, how do I figure out how to connect to data, and how do I make it easy for a consumer to say who they are digitally, right? So when I came into the space, the hardest thing was, like, there's a lot of different ways for consumers to get data, right? They could go to the medical records department, use a HIPAA auth form. They can connect to a state HIE if the state made that possible. They could connect to a national network like Care Quality, which we kind of referenced, or in a future state, a QHIN, which is under TEFCA, or direct integrations via FHIR APIs. My goal was, how do I get enough facilities represented in my app that you're able to connect and get all of your data for anywhere you've received care, which was a big challenge. And also not just the clinical side, we also connected to payers, which Brendan's going to talk about in a second, where we were able to connect to the majority of payers in the country that were mandated under Cures Act to make a patient access API available. The problem still today for me was Cures Act pushed forward the technical requirements that, or the organizations that held data, for me to access that data, but we're kind of at a place of like, it just needs to be a little bit better. And they're asking, the data holders are asking for more apps and more companies to come forward and access that data to show the reason to, a business value to invest more into those technologies. And that's where we're at right now in a little bit of a stalemate, is we really need more innovators, more companies to kind of start accessing what Cures Act laid out so that we can get to the next level.
Perfect. All right.
I'll bring us home.
Yeah.
Brendan, head of product at Flexpa. Flexpa provides patient access, so similar to what Jenny was talking about. I've been lucky enough to work on all three of the major domains of interoperability in my career. So domain one is within the enterprise. Can I connect my EHR as a platform to the apps that my providers want to use? That's step one. So while I was at Epic, I got to work on that as an integration analyst. It's pretty well done. Most apps can actually connect today. You can build connections if a hospital wants your system. It's hard, it can be better, but today it exists, and it exists for a long time. First with HL7v2, now more and more with FHIR. Step two, interoperability, exchange between enterprises. And we just heard from the other panelists, that's actually doing pretty well. Providers, 70% of providers can exchange today. We can do better to build that infrastructure out, but that's pretty good. Step three is patient access. So Cures Act said providers need to make these APIs available to patients. That's out there today. Does it always work? Do they always have a patient portal account? Or can they register and get to the place where they can actually use it? Not always. And on the payer side, where we at Flexpa work, not all payers are regulated by the CMS. So 50+% of Americans can't access that data. Only a few plans like Anthem, Elevance have leaned in and said, you know what? We're already making these APIs. We're going to make them available to all patients. So that's the gap. I didn't know I wasn't speaking on mic. Hopefully you can hear me. That's the gap. The gap today is we've done a lot, and where private industry fails, the role of the government is to step in to build the infrastructure, incentivize the infrastructure, so that all Americans have equitable access to these things.
Okay, Jennifer's shaking her head a lot.
Just trying to add animation to our panel. I'm here for the
Okay,
jokes.
so we talked, I mean, we kind of went through the positives in a great way. So a lot of data is moving, which is true. I mean, what were some of the net numbers for care quality? I mean, records per day. I mean, in the tens of thousands, hundreds of thousands.
Yeah, I mean, it's billions. The annual number is probably in the billions.
I mean,
this
it's a huge, that's a huge step forward. Now, who's exchanging those records and for what purpose, and who's being left out for other reasons? I'd love to hear some of the challenges. I don't know, Jennifer. I don't know if you want to start with some of the difficulties, challenges. I mean, you touched on it a little bit for patient access. Maybe we can start with the small players. I know Rebecca, with her project, focused on the federally qualified health centers. So they typically have this. They don't have ethics. They have the smaller EHRs. Why are they challenged to connect to these networks?
Okay, so for I like to think about Cures Act as there's three main ways that patients can access their data. Number one is through the FHIR APIs, which Rob mentioned, point to point. That means I'm connecting. There's over 500 EHRs out there, 500 certified EHRs that are on Chapel. If you connect to the top 10, you have 85% coverage, but a lot of data still lives in those specialty practices or FCQA. Did I just mess that up? That sounds right. I'm just going to go with that. There's a lot of EHRs. If you really want to get the ability for a consumer to aggregate all of their data from anywhere they've received care, you have to connect to 500 plus individual EHRs, and each of them have their own issues on how their APIs operate. A lot of the issues can be whether or not they're hosting it for their clients. It's some sort of hybrid versus on-prem or cloud-based. But what I've noticed is just a lot of the, let's say the 490 plus EHRs, they weren't thinking about interoperability until the end of 2023. So their APIs really aren't production ready. So I have to connect to a lot of organizations. Now, if I join a QHIN in TEFCA, that's great, but all those 490 plus EHRs aren't hanging out in TEFCA or even the national networks today. We still have just the top 10 players. So no matter where you connect to the data sources, I like to think of the EHR vendors as data sources, you still have this gap in interoperability. So you need to get all of the EHR vendors and then all of their providers that they represent as customers to engage at either really update their API so they're production ready or participate in TEFCA. Same goes for the payers. Their APIs some of them are good, some of them are bad.
Do you think it's a money problem for the smaller providers, smaller vendors?
Yeah, so
Would more incentives help?
So for the top 10 vendors, most of them gave away what we call the Cures Act update for free to their customers so that they would adopt the technology in newer versions or contracting. With the 490 plus other vendors, they charge their customers for that. And most of their customers are like, well, I'm not going to upgrade, and there's no more incentive dollars for me to opt into these programs. Think of MIPS and MACRA and things of that sort. So why would I update to new software that costs me more money and I'm not getting the full value of the EHR? Just think about the comments or the concerns from providers around over documentation, spending too much time in the EHR and not enough time with their customers. Why are they going to pay for an additional upgrade just to make the data available? That is going to be a big barrier. An ideal state would be that all EHR vendors participate in TEFCA and exchange at scale, and it's easy to access the data via a national network or point-to-point integrations.
But that still costs money to build that integration.
Yeah, I would say a lot of the EHR vendors, especially the smaller ones, you just have they haven't updated their tech since 2010. This isn't modern technology we're dealing with.
I think some of what I hear too is, maybe if you're a single doc practice, you've got everyone is resource strapped, right? And if you're a single doc or smaller practice, you're maybe even more strained by resources, and so you have to make decisions about how you prioritize what you're doing.
Yeah.
And if almost all of your referrals are to the hospital across the street, that's your biggest value. So I'm going to pay for that connection. Well, wouldn't it be nice if instead I could still just pay for one connection but that one connection lights up the entire country. And that's what a QHIN is. It's saying it's your single on-ramp for all of those use, all of the exchange. You have all of those services for that one project. That kind of overarching umbrella of interoperability that this country has been chasing for a while to get universal interoperability. So I think it's very important. Along in incentives, I think in HTI 1 from ONC, we saw some alignment of two big 21st Century Cures Act parts, one being TEFCA and one being information blocking. So I think that can be an incentive, future alignment of those two important regulatory incentives. And then other may be a resource issue to help them upgrade, whatever it might be, to become compliant with the certified technology needed to do this interoperability.
I think the policies are absolutely geared toward the right place. We're pulling on a lot of policy levers, some of them, again, from cures around information blocking, others in terms of incentives. But we spend a lot of public dollars for people to buy the pipes, but we're not spending any more public money to make sure that the data flows. And interoperability doesn't happen magically just because you bought the pipes. There's a tremendous amount of work that goes into actually making sure that those data flows. And those are beneficial for the country for a whole lot of reasons. It's beneficial for individual patients, it's beneficial for populations, it should be beneficial for public health data flows, but we don't fund much of it today. A lot of money went to the CDC for them to establish a more modernized public health infrastructure. Those are one-time appropriations that at some point are going to go away. And, we talk a lot about sort of the incremental ways that this breaks down. And part of that is about dedication, resources, staffing, technical sandboxes, monitoring, accountability, all of which costs money. But we don't spend a dollar for it. We're facing the same issue in the state of California. It's like we just have this expectation that somehow private dollars will fund this, but we could definitely get into this a little bit more. Market incentives can be, the market isn't necessarily going to solve this without some potential distortions around these data flows and some monetization of the data in order to support the infrastructure that is needed for interoperability to truly perform at scale for a broader range of use cases.
Perfect. Just one follow-up question. Just kind of leaning into your HHS kind of history and background. Is there a good example of legislation that you've seen or incentive structures that you've seen that have worked that could take, you could use as an example?
Well, for sure, if you think about the original Meaningful Use program in high tech, did that work to get digital medical records into a lot of healthcare systems? Yes, it most certainly did. I don't have the statistics in my head, but if you look at where we were pre the spending of those dollars, which began in about 2010, we didn't have many healthcare entities using medical records. Now, many big swaths of the healthcare system got funding to support that. They didn't necessarily get it totally paid for, but it was sufficient, again, to put computers on desks, right? But now we're to the point where we don't have the same, sort of support for the ongoing costs of maintaining and improving that infrastructure.
Brendan, go ahead.
People tend to focus, and we focus a lot on the incentives, the money, things like that to get things done. If you actually look at I think about authority. You think about the authority of the ONC, the authority of the CMS. It's kind of convoluted how we get health technology built today. The ONC has to use the Certified Health Technology Program to add new features, bend over, flip over, do backflips to get new features added in. And then the CMS says, okay, providers who are participating in CMS programs, you have to use certified tech. And everyone sort of hand waves away. That's not all providers. But providers, by and large, just follow that. The CMS, in terms of regulating payers for infrastructure, doesn't have much authority. In their recent rules, they say, we're going to use the Social Security Act. We're going to use ACA. We're going to do things that have nothing to do with healthcare infrastructure. So if we actually want to regulate all these players that deal with health tech, not just the certified health technology, not just the CMS providers, not just the CMS regulated plans, there's an aspect of authority that is missing towards the CMS, towards ONC, towards other departments that could be involved, the Department of Treasury, Department of Labor. And so I think a lot about the authority that's missing to build comprehensive, ubiquitous infrastructure. And I think that's where policy comes in.
Yeah, I don't know if I really didn't want to talk about the legislation as much, but I wonder, or not legislation, but the enforcement. I mean, currently it's the Office of the Inspector General that has to step in, and even there, because there have been mandates, 2022 with the Fire API, that was expanded data types, December of last year, but there seems to be, there isn't much enforcement, or there are challenges with enforcement. And,
What-
yeah, go ahead.
My opinion on enforcement is, right, you need to, the way that it kind of works, there's a decision tree matrix that ONC put out that's useful, but ultimately enforcement works like this. I would have to report an information blocking complaint to the ONC, and then it would go through kind of a triaging to decide, does that get passed to OIG to investigate, and then to other offices, maybe OCR. Deven can elaborate on this. I think a lot of people are afraid to file information blocking complaints. I am. I often hope that I can work it out privately over email and try and convince the in-house lawyer that their interpretation of Cures Act is incorrect, which it usually is, and I'm usually right. But a big problem is, this goes back to my point about the 490 plus other EHRs. They don't have regulatory teams. They don't have people to help them assess their obligations under the law. Really, they were just trying to check a box under certification, and then they rely on the certifiers that they hire. There's only mainly 2 certifiers. I can tell you one is good and one is very questionable. And I think that there's an education issue under the responsibilities of the rule. We haven't had the provider final rule come out. The penalties for providers hasn't come out. So I think we need to, once the provider penalties come out, right now only the penalties for the cert tech vendors and HIEs and HINs are out. I wonder if the conversation will change. We need to see how they decide the provider penalties will fall, because that will incentivize the providers to push their vendors to make the data flow, potentially.
Yeah, I'll add a little bit, maybe not necessarily directly related to what Jenny was describing, but I think maybe it's optimism in me, most providers in this country want to do the right thing to help people get well, stay well, and future generations be healthy, right? And it's hard, though, to do that when there's so many choices about what to do. And so with interoperability specifically, am I doing the right thing? Did I do enough? Did I not do enough? What should I actually be doing? And that's an education aspect. That's an explaining everything to folks. But if we can make it easier to do the right thing, or explain what is the right thing, because right now information blocking is more about, don't do this. Okay, what do I do? And I think we owe it to the providers and this industry to say, here is what to do to be successful with interoperability. I think TEFCA has a really good opportunity to be that vehicle to explain to folks, this is what to do. And then we can get behind that, help this country move forward, and hopefully not have to rely on disincentives or some of those things too much, the stick approach. So anyways,
I think it was also a challenge. It's a cultural shift from, the land of HIPAA, where it was, well, you can disclose for all these purposes, and you must disclose to the patient when they've requested it. But it's really in your discretion. So each entity that held data that was regulated by HIPAA, which is most doctors, hospitals, and health plans, they made their own decisions about when to share data. Consequently, that didn't work very well. The information blocking report that ONC put out, and then Congress responded with the information blocking rules, basically put a thumb on the scale to say, we actually expect you to share data unless there's a good reason why you're not. It's not an absolute. It's not a you must share in all situations. It's a little bit situational. Did I withhold this data because I actually didn't trust that that entity that was asking me was a legit entity? That they're putting a request in for the patient, that the patient really hire that app, right? I have a lot of questions about whether that's actually occurred. And am I asking those questions legitimately, or am I putting privacy up as a reason why I'm not sharing, when it's actually because I don't really like that entity, or they compete with me, and if I send them the data, my patient's going to go where that data flows next. So how do you get the sort of proprietary, this is my asset, as the reason off the table as the reason why that data doesn't get shared when it lawfully could have been shared, versus how do you still allow for the legitimate protective instincts that exist in these entities not to share data in a way that could end up harming the patient. OCR just finalized a rule around putting prohibitions around disclosure of certain types of data that might be used to penalize a patient or her medical provider for the delivery of what was lawful care in that particular state. So what does that mean juxtaposed against the information blocking rules where people are starting to get it in their head? That means I must share all the time, or if I don't share, somebody's going to complain, I'm going to be subject to an investigation, I'm going to have to spend money to defend it. We haven't sort of, we had this environment where we had thousands of gatekeepers around siloed data. We didn't want that. That was not good. I agree with that. But now we haven't quite figured out who plays the gatekeeper mechanism. Can we do it all through technology? What policies do we need, and how do we layer in the right accountability?
To what Devin's saying, though, I think it's really important to know that there are organizations doing this well right now.
Yeah.
There are organizations that are doing it well. It's bringing everybody up with them so that everybody's kind of following the same behaviors.
Yeah.
Yeah, and talking about enforcement gets into trust. And early in the history of the networks, so the exchange between enterprises, there was a lot of trust. These were EHRs exchanging with other EHRs on behalf of providers. In the effort to get to those providers, those specialties like oncology, obstetrics, that have really specialized EHRs that struggled to join the networks, on-ramps were created. Companies that made APIs that were easier to use, that simplified the process. And that helped more EHRs and other participants join these networks. And now we're at a crisis where these networks have let in people that are not providers. And they are accessing data without permission from the patient, and they're sharing it with people that don't have any right to have the data. The wolves are inside the gates. And so we are at a moment right now in health technology that I don't think people know there's this crisis and that we could buckle under these pressures and fall back 10 years or 15 years. So that crisis right now, addressing that crisis and moving forward to TEFCA, which creates paved paths for these use cases, is the biggest challenge of our time, period, full stop.
So I know you're quite vocal about this, and you have some ideas about strategies. What are some ideas to address, this lack of trust?
Trust is you foment trust in two ways. One is knowing the people you're exchanging with, right? If I'm Sutter and I know you CSF, well, sweet, you're down the street. I know you. But in a big enough network, you don't know everybody. So the only way to foment trust, to build trust, is transparency. Is to say very clearly, here's who I am. Here are who my providers are. Here's what I'm doing. Here's full details of my business. And by putting that out there transparently, by leaning in, by sharing, I can go and look somebody up and say, oh, I understand what they're doing. They're not a law firm. They're not a pharma company. They have a virtual care wing. Oh, Clover Health. You're actually doing virtual care. That's why you're on the network. These things don't exist today. And so there's mistrust, because when there's opaqueness and I don't know everybody, I can't possibly know everybody, then we fall into doubt, into worry. Are they abusing patients' rights? Are they abusing my rights as a provider organization? And so that's where we stand today, is we have to decide, can we be transparent? Are we willing to share that level of detail to build this infrastructure that allows ubiquitous sharing? I think we can. That's going to require a mindset change, some rule changes, and some push from the government.
I think, in order to advance medicine, we do need to share data with all sorts of exchange parties beyond the traditional walls, like Sutter UCSF, right? But I think we need to do it in a way that I think what Brendan was getting at is like not kind of trampling on patients' rights. And so we need to make sure that there's transparency with the patient as well, with where their data is going, that when they're signing up for something, they're not getting duped by this really long thing that nobody ever reads anyways. It's like, oh, I didn't realize that that's what I just signed up for, kind of thing. So there are some risks. I still remain hopeful, though, that the TEFCA, the governance structure of that, can help avoid some of the maybe pitfalls or mistakes of the past, and we can, again, create that trusted first-D exchange framework for the U.S.
I think, just to tie it all together, right now patients can access, as we talked about this, there's a difference between point-to-point integrations where you're you're maintaining, 510 plus integrations, right? Versus one integration to a national network, which is, akin to cellular networks. I think that we're living in this kind of world of Cures Act calls for one way to implement, and we're trying to move towards TEFCA, which is another way to implement, and we're in an in-between state, and it's a question of how do we get everybody to move towards a national network for exchange, so it actually reduces the cost of technology and integrations and maintenance around that and resources, but also all multiple uses can be supported and all stakeholders get access. I mean, that's really the dream.
I want to put it in terms of less of morality or ethics, because it is like a lot of times it's framed as like we should share, patients should have access. Those are true, and that those morality, those ethics apply. But the bigger thing here is that the waste, the billions and $1 trillion of waste in the industry go away if we build this infrastructure. That's the real call to action. If by making the patient able to access their data, by having frictionless exchange between the parties involved in healthcare, the waste goes away. And we become a way better society and nation as a result of that. I think that's what keeps me inspired. And I think this whole panel inspired.
The only thing I would add to the recommendation around transparency, and I'm in agreement. I think I agree that TEFCA is where we should be heading. The idea of a single on-ramp versus having to connect for the patients that we serve, who most of whom have rare diseases and who see 5 to 6 medical providers and would have to connect through FHIR APIs and retain those connections across all of those providers over time. The idea that it could be, sort of one place, one query, getting the data from everywhere. Transparency is important. I keep the adage, trust but verify. We don't necessarily have the right mechanisms or entities in place for doing the diligence of, not only are you transparent on your website, but what you're saying that you do is actually true about what you do. Yeah. Versus, here's my story, and that's the story I needed to tell so that I could access a network under the only permitted purpose that is available to me, which is treatment. So I got to come up with some way of wedging myself through that hole, and frankly, that there could be more fraud that gets perpetuated through those kind of more open pipes are good as long as the rules are followed around how those are opened and the use cases and who's acting. The patient, I would be happy for anybody to scrutinize what we do. 100%. I think we're truthful, but yes, our privacy policy is way too long because it's a legal document and not as easy to read as it should be, as well as our terms of service. Whatever I can do to make it more clear and to have people sort of open up take a look at what's under the hood and what we're really doing, I would be 100% happy to submit to that.
So I want to highlight transparency, and from what I'm hearing, it's transparency about access, who's accessing the network, what their purpose is. Is this for treatment? So transparency around purpose. Because as you say, there are people accessing under the guise of treatment, even though it may not be currently. So we should maybe open up to more treatment categories. I don't know if you want to touch on that in a second. And then the last area is, do you really need access to all the data? Should there be some sort of oversight or a limit, or should you only be pulling the data that's necessary for the purpose intended at that time, or should you be able to hit the network 100 times a day all year long? I don't know if you have comments. I know those are, go for it.
So, purpose of use is really important for healthcare. It's important outside of healthcare. If you look over at the in fintech world, Dodd-Frank led to 1033. 1033 requires open banking, and the Consumer Protection Financial Board has just put out their proposed rule. Very similar to what we see in health tech. So, despite the narrative, fintech lags health tech almost all the time. So you can take that hot take wherever you want. And in it, they say, okay, you have open banking. You can pull your financial data via APIs. Before, you could use screen scraping. And you can't use it for anything other than the explicit primary use. There's no secondary use. So it says when you pull it, you have to use it for exactly what you say. That is not the case in healthcare. Secondary use is 100% the law of the land, expected and ubiquitous. And it's kind of messed up. So to Devin's point, I can say, oh, I got one provider on staff. I'm going to claim treatment. I'm going to pull data for treatment. I'm going to immediately turn around and sell it to pharma. I'm going to immediately turn around and sell it to life insurance. All these things exist today because we have for whatever the reason, secondary use in healthcare is very accepted. I think we need to start to question that. Maybe secondary use still is accepted, but it needs to be absolutely transparent. It needs to be stated when pulling data. It needs to be made available to the patient to consent. And I think as we start to shift that mindset and lean into the transparency of purpose of use, both primary and secondary, as we do transparency of organizations, to Devin's point, if every organization had that level of transparency she just described of saying, sure, I'll tell you who I am, I'll tell you what I'm doing with the data, then we could trust. And then transparency to the patient, both in terms of where their data is and who's accessed it, then we'll be in a good spot. But if we don't have those things, we're going to have mistrust, we're going to have problems, we're going to have failures.
No. Rob, any thoughts, Rob?
It's hot up here.
Okay. Metaphorically speaking. All right, perfect. So we have about, I don't know, it looks like 7 minutes. So, did you want to say something or not? No?
No, I'm okay.
No, I saw Jennifer's animated hand. But, I think we all drink the Kool-Aid. We're all very excited about the potential of interoperability in the future, for interoperability and what it can offer. And maybe just for the last round of questions or comments, is there one aspect that you, maybe in your role, you can talk about Ciitizen if you want, where do you see this really just, opening up all kinds of opportunities?
Well, again, if it's easier for our users to be able to get all of the data from all the places that they've been seen in one place so that they can manage it and control it and share it, it really allows them to take greater control of what's going on in their lives, to involve a caregiver in what's happening, for caregivers to be able to manage that care, and for them, if they want to be able to contribute to the development of cures. Again, we serve a lot of patients with rare disease. That is a primary focus for them. There is no standard of care often for what's going on for them. Treatments, in order to spur drug development, if they come to developers and say, we have the data, please look at it and help us learn more about what's happening and help us develop preventive strategies and therapies. So I've been bullish on the patient access pathway in the same way that Jennifer has. Brendan, I know Rob is incredibly supportive of it. It's not the only interoperability pathway, but when we put the patient really legitimately in the center and allow them to both access their data and have control of where it goes and the ability to launch it into spaces that maybe it's not being shared that way, you open up all kinds of avenues for research and development, all with the knowledge of and consent of the patient, which certainly feels better than a gigantic commercial data play where the patient often has absolutely no idea where their data has gone.
So very patient-centric.
Yeah.
Yeah, a little bit of a recap, but I still think the fact that we have 30% of providers in this country on the sidelines is a big problem. And those are gaps if you believe equitable care is interoperable care, and having the whole complete and accurate patient medical record is a key to that. Then we need to help those 30% find clarity, which I think TEFCA can bring, and get the resources to get connected so that wherever the patient goes, the record can follow them. We can save lives. And I think that needs to remain an absolute focus. I am also excited and hear from our community a lot that they can stand up. Right now, they've got all of their FHIR APIs. They're all on open.ed, like they're all there, but it's still a little bit challenging. Still have to connect. I think the opportunity for TEFCA to bring that in a safe, secure, scalable way is incredible. To promote patient access, whichever app the patient wants. TEFCA also raises the bar and says these these apps now voluntarily agree to HIPAA privacy and security rules. That's great. I think that's a big differentiator for TEFCA. And then, again, certifying public health, you had mentioned the dollars that CDC has and others, the stilts and how that reporting happens. Our customers often have to do kind of duplicative reporting right now. They might actually send electronically and via paper because there's just institutional workflows, upgrades on the other side. So I think it'd be great to have certifications on the other side that, those catching the data, we have the same type of experience, and we can turn off those, the large amounts of waste. And same with the payment operations, having those purpose-built implementation guides and ways to do things addresses your comment earlier about what data is needed, why, to whom, when, and then how do we do it all. If we have purpose-built guides, we know we're all doing the right thing, and that gives assurances to the covered entities and to the patients that their data is being respected.
I think for me, just my experience in interop and the roles that I've taken on, whether within my organization or on boards or committees, is it's a cost for me, right? Interop is a cost. So how do we reduce costs? Because if we can reduce costs and increase adoption, we're going to benefit from that. So I think of it really as, a girl in a garage trying to start a company and trying to make something cool that changes consumer behavior. Anything that makes it easier from a technology perspective for innovators to adopt this technology should be a focus area, taking into account everything else said on the stage. And then, for me personally, it's just women's health, just thinking about, the majority of people who consume healthcare, women, as soon as we maybe we get married, have kids, and then we start managing the health of our children and our parents, and we're sandwiched between those two generations or our partners, we consume a lot of healthcare, and we need quick and easy tools to do that kind of management, or donate to research, or just anything of that. So think of it from your day-to-day lives, but also how do we help the Flexpas of the world or the One Records of the world get to market fit faster.
Two call to actions beyond the ones I've already said. The first is that providers need the guarantee, or maybe not guarantee, but just the urging of the government that they will not be held liable under HIPAA for releasing information across these networks. They're afraid. They're afraid to release the apps because they have liability under HIPAA. And if these apps are doing bad things, if someone gets in inappropriately, that's a HIPAA breach on their side, not on the app side. And so HHS, the ONC, putting something there to say it's okay. The app that is querying is responsible would lead to greater adoption. That's one. Two is we, Flexpa, put out a report today on the state of CMS payer patient access APIs. And so if you look at that, it's okay. About 80%. We're about 80% of the way there through CMS regulated populations. The biggest population that is regulated that doesn't have access is Medicaid populations. So fixing that, getting the 20% of Medicaid populations that don't have access because their states haven't turned on their APIs, that's a big push. And then getting the other 50% of Americans on commercial plans who are not regulated by the CMS to have the same level of access is another big push. And that's what we need to do, because we need access not only to our provider data, but also our payer data.
All right, 20 seconds, amazing. So that concludes our panel. Thank you so much for taking time out of your busy day. I think it benefited everybody. Thank you.